Hello and welcome to Salvaging Sex. Today's guest, I'm so happy and so honored to have her here. It's Dr. Kelly Casperson.
Thanks for having me.
Oh my gosh, so excited to have you. Okay, so Kelly, tell us tell us, let's start from the beginning. Tell us about your background. Where are you born? Where did you grow up? When did you decide to become a urologist? And how did you even find that track?
Yeah, so I grew up on the shores of Lake Superior, Duluth, Minnesota, oldest of three, and I was always the smart kid. I loved reading, like I loved thinking about stuff. And I was sitting in my car, in my mom's car, I think in high school, and I was talking about like dabbling, kind of being in, no physicians in the family, right?
Hmm.
And she's like, if you want to do that, you decide you want to do that, and then you commit to it. It was something like that.
Yeah.
And I was like, okay, that's how you become a doctor then, right? And so that's what I did. Amazing mentor at the University of Minnesota. And I met with him, and his name's going to come to me. And he was a urologist, and I was like, I'm kind of thinking of like ER, OB, or urology, right?
Hmm.
I kind of like ran through it with him, and I was like, the miracle of delivering babies, but fuck 2 in the morning. And then the ER, like working at a level 1 trauma center, how much awesome dopamine is that? But there's usually one in every state. And then you're dealing with like sinus infections and domestic abuse. And
Hmm.
and only you can only see the path backwards, right? Of like fast forward, I became a urologist. I've been doing it for a while. And now I understand urology protected my soul, right?
Oh, yes.
Like to be able to stay in medicine because the OB and seeing the trauma, the stories, the child abuse, the issues that create babies, right? Like
Yeah.
the drug, babies born drug, like my soul, it would not have stayed protected. And same with the emergency department, right? Like
Yeah.
society's ills day in and day out. And so now I understand urology to be like, I needed my soul protected. I would have burnt out and quit medicine a lot earlier because people don't know this. Doctors are not taught how to process trauma. We are not
Ooh.
taught how to take care of ourselves. Like we are thrust into a system of you be the savior and you can't save everything and you're not given any
Hmm.
resources to deal with you not being able to
Hmm.
save everything, which you thought you were going to be able to do. Right. And so like there's so much, trauma in becoming a physician. And I think urology really protected me so that I could
Yeah.
stay in this game to where I am now.
Yeah.
Uh, so fast forward that, loved training, loved urology. I love the instant gratification of it. Like because you showed up today, so like this kidney stone's gone, the cancer is cured, and now your
Yeah.
bladder's drained, right? Like tons of instant gratification, which is
Yes.
sexy as hell. And then I was 7 years in private practice and I was bored. Like monotonous recurrent UTI. What the hell am I doing with my I went through all of this training to just tell people to drink more water, pee more frequently, and use vaginal estrogen. Right.
Yeah.
Like, what am I doing with my life? And it'll just keep coming until you decide to retire. Right. And
Yeah.
I had a attending in residency who had all the residents over one night. And he said two things. Number one, your most expensive investment is your relationship and your marriage. So choose wisely and work on it, right?
Hmm.
And his second piece of advice was watch out for the 7 year itch. And he's like, whether it's your job or your relationship, at 7 years, shit happens, right?
Yeah.
You get bored, it gets mundane, you get distracted, whatever happens. And I was like, oh my God, I'm 7 years in. This is the 7 year itch, right? And
Yeah.
I knew it, I was kind of primed for it. And like at that moment, the universe was like, you're ready. And I truly think the teacher shows up when the student's ready, you know? And I had this patient that I had treated for bladder cancer, cured her invasive bladder cancer back in the beginning of the world when I was doing cystectomies in private practice. And she came in and she was crying and it was about her sexless marriage. And the unique thing about that, besides it being 7 years, was that I was very bonded with her This
Mhm.
wasn't some stranger who I was like, what's her problem and why is this important? Right? Like I was
Yeah.
very bonded with this person. And I was like handing her the box of Kleenex and I'm like, I don't know how to help.
Mhm.
Like that was the moment where I was like, does anybody know how to help people with sexual health? Because I was told in residency, number one, do a fellowship so you don't have to deal with women,
Mhm.
which I didn't do. But I was also told, women are complicated, they're difficult, they're challenging. I was told we will never figure out women's sexual health. This is to like, that's what I was told in residency, like, the kings of Viagra, right?
Yeah.
In urology. And so I was like, at that moment, I was like, is it true that we don't know?
Yeah.
And that's when I started reading all the books. Went to my first Ishwish lecture conference and was like, the gynecologist I went to med school with was there. And I'm like, what are you doing here? And she's like, we didn't learn this either. And I was like, oh, so the gynecologists don't know how to help women with this either. Got it. Read all the books. And I had this voice inside of my head. And this voice was like, you need to talk. And this voice was annoying. Like somebody's talking to you, voice annoying, right? And I loved podcasts. And I was like, but I don't know enough. I had learned by then that there was one fellowship for female sexual med, and I didn't even know it existed and didn't
Mhm.
do that fellowship. So I'm like, I didn't do a fellowship, so I'm not qualified enough. And I was waiting for permission. And I had a couple of people in my head that I thought were the people who would call me and give me permission. And
Uh-huh.
was getting out of the shower one day, and lightning struck again, and was like, the permission you need is your own.
Ooh, yes.
I know. It's such a good start. And so I started the podcast 4 years and 4 months ago. It's like
Mhm.
top 10 in medicine, top 50 in health and fitness now. Like, and through the podcast, oh, by the way, the voice goes away when you do what it wants because it's actually your future self calling you forward. For anybody who has the voice and doesn't know who it is, that's your future self. So she got quiet. And started getting into hormones then because people are like, well, so I wrote the book, started the podcast, and then women are like, but you know what happens with menopause? You know what happens to your sex life with menopause? And I'm like, no, like I'm staring down the barrel at it. I'm in my mid 40s. What's going to happen? Right. And
Mhm.
they're like, well, estrogen kills people and it causes cancer. And then your sex life goes to shit and blah, 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 blah. And then it was the same thing. Is that true?
Mhm.
Right. So started doing the research and I'm like, oh my God, people are scared of like the oral medroxyprogesterone where the placebo arm was flawed from the WHI in 2002 and we've moved zero forward.
Yep.
Right. And so that the podcast really started talking a lot more about midlife hormones, menopause, why are we scared? And then it's the incredible bullshit of like, you mean we've got cheap and effective medications with decades of safety data that nobody uses and it decreases mortality? Like
Yes.
the pharmacologic holy grail is something that decreases mortality. Statins don't even do that for women. Baby aspirin doesn't do that.
Yes.
High blood pressure meds don't do that.
Yes.
We've got hormones. And so really like I sit now in the Venn diagram of sex med, hormones, and then testosterone, specifically testosterone for women, because that's to me, I'm like, why testosterone makes estrogen? It's actually wrong that ovaries make estrogen. Ovaries make testosterone, which makes
Mhm.
estrogen.
Yeah.
So that's been very fun. That's my current favorite thing is females and testosterone. Because libido is a mood, by the way.
Mhm.
So if testosterone improves libido, aka changes your mood, how come you say it doesn't work on your brain?
Yeah.
So
I
testosterone's fascinating to me. Absolutely fascinating. Socioculturally, for all the different reasons. Oh, and I did a TED talk in the middle of that about adults not having any sex ed and why that's like wrecking our relationships.
Ooh.
There, boom. Hope that
So
wasn't too long.
Um, so many things from that. Holy shit. I loved everything you said. Let's see, I took some notes, and so there's just so many things I want to circle back to. Is I totally resonate with urology saved my soul. I feel like I was still like disillusioned by the system always. I always just have been, but I think I did not realize how much of a privilege it was to be a urologist, to have resources, funding, have a training model that not only thinks about disease states, but also quality of life after said disease treatment, have access to research and industry, and this kind of idea of, well, if we don't know, let's do a trial and figure it out. Like this, instead of just like, oh, this is how it's always been done. And there's still definitely like dogma and tradition in urology, but it was always kind of a little bit more of a spirit of innovation. Um, and I think that training model is really what helped you to see how fucked things are once you started doing women's health. Once you were like, wait a second, why, why did, why did it, why actually is it like this? Because we are so hyper focused on specifically the quality of life of men and how easy it is and how evidence based it is, and how we have insurance and coverage and all these things. And then you get over to the women's health side of things and looking at the quality of life, and it's just not even addressed. It's just not even addressed. And then the patients are then blamed and said they're difficult when all they're asking for is a quality of life. Their difficulty is really our ignorance of the medical system.
Well
And
said.
I was not privy to this until I did Goldstein's fellowship. And I think I call this training, learning about female sexual health, learning about menopause, a superpower, because it makes you just a better, well-rounded clinician and physician and carer. And I just love that you then took that knowledge, listen to that voice in the back of your head, kind of Voldemort type, like,
It was persistent for sure.
and then said, I'm going to speak up on this. I'm going to start speaking up and speaking out, and educating the masses. And I also love what you said about waiting for permission. I think so many people are scared to speak up, are scared to do big, brave things because we're always waiting for someone to say it's okay. And you said, fuck this. I'm giving myself permission, and look at where you're at today, right?
Yeah.
Like just night and day, like one of the leaders in this space when it comes to speaking on and speaking up about menopause and sexual health and how it interacts and intersects. Like that is just so amazing.
Yeah.
Um,
Yeah, I mean, I started out MD PhD. Like I was
mhm,
that nerdy, right? And then I
yeah.
was like, oh my God, I hate microscopes. I hate grant writing. Like this is not, and I like really want to get out and help people, right? So it was like not okay. And I think in the medical system, academic, world we grew up in, research was put on a pedestal, right? And
Mhm,
you'll still hear this. We need more research. We need more research.
mhm,
You know, Dr. Biden right now, we need more research. And to me, in this role of medical translator, right? Like my superpower is explaining complex things simply so people understand. And I'm like,
mhm.
we need more translation. We need the doctors that practice in this country to know the research. That JAMA article that came out like last year saying it takes 17 years for like solid, good data to actually trickle down to the people. I'm like, my women can't wait another 17 years for more data. We need to start using what we have now. And really, that role of translator, which was never talked about in our training paradigm of like, you do the research and that's how you help people. It's like,
Yeah.
your research will stay behind a paywall, honey,
Yes.
unless
Yes.
there are people that will then take it out and say, why aren't we doing this? Why aren't we doing this?
Yes.
So to me, like I've full on, come into it like there still hardly exists the job of the translator, but I see that now. That's my job with the podcasts
Yeah.
and the books and the TED Talk is like we've got some data. We're gonna die waiting for more, and it's gonna be behind a paywall anyways,
Yeah.
unless you have people who will speak it.
Yeah, that was always something I found so interesting. We'd have journal clubs, every month or so, and we'd look at the newest article and blah, 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 talk about it. And then I was like, guys, did we write this for us or did we write this for the patients? Like these are things for the patients. Why aren't we talking about science communication and how important it is to then, like, I'm a big believer that research is advocacy, and if we are not then doing the work to then tell people about the research that was already done or has been done, like we're failing. We're failing the population and leaving them kind of prime for these like charlatans, for these like fake charmers, for these like misinformation. If we're just staying in our ivory tower, in our little ecosystem, having our journal clubs, and then not dispelling this information to the people that are going to be affected or treated, or their clinical care could potentially be changed or helped by this information, like what are we doing? Why
Yeah,
are
I
we
mean,
doing any of this?
like on a boots on the ground, is that's your taxpayer dollars funding that research.
Oh, yes.
What is it doing behind a paywall?
Yes, 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 yes. And then we have a critical mass of like, 2020 where people are like, well, I don't trust the physicians because they're not the people that have been talking to me this entire time. I trust this guy in his mom's basement who is telling me to do this. And like I've formed a relationship with him, period. Like I'm
Yeah.
gonna trust them over the physicians that have ignored me for all
Yep.
this time.
Yeah, I think a really current example of this is birth control.
Mm, yes.
And because what I'm seeing is a lot of people trusting these people who don't have your best interest, or maybe there's a political interest or whatever else, but they're telling you don't be on your birth control because of X, Y, and Z. And then the doctors are like, that's not true, or blah, blah, blah. And I'm like, but the distrust, doctors never told women there was any side effects to this stuff.
That's the tea. Oh my God. I could talk about this all day. And it's like the birth control conversation is such a nuanced one. It does a lot of good, and also it has side effects. And when those side effects happen, for my listeners medically, it can potentially cause painful sex, feelings of recurrent UTIs, dysuria, pain with urination,
Depression.
depression, like it can cause recurrent yeast infections because it changes your hormones, and your body is very dependent on hormones. And so when you're getting a prescription for oral birth control or any of these birth controls, oral has the most side effects. It should be a shared decision making of, hey, this is why we're doing this, and this is the potential complications. Those conversations aren't happening. And then when the patient comes back with pelvic pain now, or recurrent UTIs, or recurrent vaginal infections, or all these other symptoms, we're then gaslighting them and saying, nah, that's weird, and then going on their way. I equate what is happening with birth control and the side effects that are happening with birth control to like being started on a blood thinner, like warfarin, which that blood thinners help to, for our listeners that are non-medical, if you have a blood clot, it helps to thin your blood to like essentially help to disintegrate that clot, and also to prevent things like strokes, heart attacks, all the things that the clot could potentially cause. So that means if your blood is thin, you're going to bleed more. So what's happening with a lot of the people on birth control is it's equivalent to being on warfarin, getting a cut, and then going to the emergency room because you can't stop bleeding. And then everyone at the emergency room is like, that's so weird that you're bleeding so much. I don't know what's wrong with you. Maybe you should drink some wine and you hate your partner. Like, it's like that is what I equate. Like, there's no way that anyone would get a prescription for warfarin without, you're going to bleed. Bleeding is a complication. Bleeding, bleeding, bleeding. Why aren't we having that same discussion around, the potential side effects of birth control? Because I think if we were actually having real conversations about it, people would still probably take it because it's what we have so far. And
Birth control is amazing. It's changed.
right?
It's changed the world.
Exactly.
When you play with hormones, there are side effects.
Yes.
And because physicians don't tell women about the side effects, I think they're more liable to like listen to the people who are telling them how bad it is, because
Exactly.
they're like, you know, it's it's an honor to care for people. These conversations are long. The doctor-patient relationship is sacred and it's being eroded. You can't have these pros and con conversations in a 10-minute visit.
No, no, and that is such a like how, I mean, and this is not a question that I anticipate that you just fix it, but like how do we reimagine a world? How do we maintain good quality healthcare with health systems that are promoting bad care, right? Like how do
Yeah.
we as physicians even address that, and how what's been your experience with this and what has been like some of your thoughts on
Yeah.
it?
I mean, I joke around. I'm like, I worked really hard to be really lazy in clinic now. But it's because like I wrote a book. I have a
Yeah.
YouTube channel. I have 261 podcast episodes, right? So like to me, I'm like, listen, I put it out there. Maybe you didn't know that before you came to see me in clinic, but now you know it. Go out, get because the educated patient, whatever you want to call it, educated human, patient, consumer, person of the world, the more educated you are, and I'm not telling everybody
Mm-hmm.
to go to medical school, but if you don't know what a urethra is, if you don't know what a vulva is, you cannot have the in-depth conversation that you think you want with your doctor, right?
Yeah.
If you come in, you already know the FDA approved medications for low desire in women. You come in and you already know that transdermal estrogen does not increase your risk of breast cancer. You come in and you're already educated, which is info you're going to get from listening to my podcast, right? The level of conversation that you can have is elevated beyond compare.
Yes. 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 I just so strongly believe in that. And hence why I'm creating a whole company around this idea of an educated patient as a powerful patient. But it also helps the doctor. One of the constant questions I get is like, well, what if the doctor doesn't believe the patient? And I'm like, well, one, it's evidence-based stuff, so that's on them for not being up to date on the evidence. But also, two, a doctor should, in theory, I anticipate a lot of doctors also being like, oh, thank God, I don't have to explain what the clitoris is or where the clitoris is or where like hormones and like I spent some every time I was in clinic, um, and I was in clinic a lot, um, when I would have a scribe or a medical student with me, by the end of the day, they're like, Dr. Uloko, I could do what you do. And I was like, yeah, you could, because we just talked about the same goddamn thing 30 times. Like, you're 100% correct. By this time, you've actually completed this day of clinic was a whole fellowship, right? Because we're saying the same thing. And this is not just in sex med. This is also in our urogynecology fellows. A lot of those women and people with vulvas are having crazy changes in their anatomy. Like, I don't know. I think it's strange that the bladder can just fall out of the body, or like your vagina can just fall out of your body. So I totally can get why that person in their office is terrified and wants all the information. But for them, they're just like, yes, your organs can fall out. Yes, there are options. Yes, these are other options. How much better would it be? How much of a better clinical experience for doctors if the patient was like, "Oh yeah, no, I already knew about the options and I'd like to talk to you about them," instead of the doctor being like, "This is your uterus. This is your vagina. Sometimes they come out." Like these like really rudimentary things. It just leads to faster care, more higher level of care, and it's kind of the best way to at least work within a system that's not giving patients the adequate amount of time to get high level care. So I love
Yeah.
that. I think that's a great answer.
And not
Um,
everybody wants to be a podcaster or wants to write books or blah, blah, blah. But it's really like find the resources that you think are reputable, refer your patients to them, put them on your website, have them read them before they show up. Like there's so many different things you can do to get to the like how many doctors have reached out to me and they're like, because of your podcast, a patient came in, she wanted vaginal, she knew it was safe. Like everybody's day is better
yeah,
with
yes.
an educated person.
Absolutely. I mean, I've talked to you about the amount of people that I've met just in the most random situations, and menopause comes up, and they're like, "Oh, I learned that from Dr. Kelly Casperson." I'm like, "I know her," and they literally lose their shit. They're like, "You know her?" I was like, "Yeah, she's a real person, and like in real places." So your work, I can attest to how your work has empowered people to know themselves, know their bodies, and also know their options out there and not be gaslit. Because that medical gaslighting around women's health is so rampant. And I know statistics are like 76% of women or femme presenting people in the healthcare system have experienced some sort of medical gaslighting, and I would not be surprised if that number is higher. And it is arming them to protect themselves from bullshit. Like, no, estrogen's dangerous. It's like, what study? Where? The WHI? Did you not read the sub-analysis or update yourself? No. So that's amazing. Speaking of communications, you then wrote a book. Walk
Mm-hmm.
us through that process, because that is, writing a paper is one thing, and I find that very difficult and stressful, but I love it, the end result. Now you wrote like 70 papers
Right. Yeah.
in one.
Listen to me. I'm like, I dropped out of a PhD program because I hate grant writing. And then I'm like,
And then
I'm
you
working on
wrote,
my second book now.
yeah, like walk us through that process, and how you came up with the idea for the book, um, and then your process of getting it out into the world, and what was the thing that you were the most proud of once it was out?
Oh man, I'll start with that. When women tell me they cry and when women tell me they laugh.
Mm.
Like I've gotten both from the book, so that's how good it is. But you'll laugh
Yeah.
and cry. But when they say they share it with their husband, when they say they gave it to their adult sons, when they say they bought it for, a baby showers, like whatever. When people say how it affects them and what they've done because of it, that's dopamine that you can't get enough of. Yeah, so I mean, I created it because I read, like I said, lightning struck. I didn't know how to help somebody, and I wanted to question the belief that nobody knew anything.
Hmm.
So just started reading. I'm a voracious reader, and just started reading, and I'm like, okay, sex books, we'll call them sex ed books for lack of better. They come in two flavors. One flavor is there's a stiletto and fishnet stockings on the cover, and it's all about how to be the sexiest, desired thing ever. That's one genre. And the other genre is I have a PhD, so let's not have any margins in this book. Let's make the font 10 point and let's write to a level that you don't really understand what they're saying because it's like a dissertation, right?
Yeah. Yep.
And so I'm like, that's what we got. I'm going to write the sex ed book that I want to read, which is
Yeah.
you can finish it in a weekend. We're talking less than 250 pages, right? So it needs to be short. It needs to have humor. It needs to be written in a way you can read it. It needs to be like practical, right? Like
Yeah.
the average woman is not going to go out and buy fucking 5-inch stilettos and fishnet stockings. And if she does, God bless her. But I guarantee you that's not actually the solution to society telling you that your body is gross, your body image issues, the heteronormative gender bias that's in your relationship, right? And the fact that your vulva is changing and your boyfriend at age 18 told you to never use lube, right? So it's like, buy 12 vibrators if you want, but it's not going to get you too far because
Yeah.
we got to uncover this biopsychosocial.
Yeah.
So that was the book. It did incredibly well. I was basically like, I don't know the publishing industry, but I don't really want to get to know it. It seems like a beast, and you got to get
Hmm.
agents and you got to like do stuff. And so I self-published it. It did very well. Then Hachette Books basically called me because they found me on the internet, and they're like, can we buy your book and will you write another one?
Amazing.
So I did it totally, yeah,
Congratulations.
I did it totally backwards because they're like, "Will you write another book about sex?" And I'm like, "Well, sure, but I kind of think my next book is going to be about menopause and hormones."
Yeah,
And they're like, "Oh, okay, write that." And I'm like, "Oh, apparently you just tell publishers what you want to write and they agree to it."
love it.
Right. And then I was like, I should probably get an agent. So I did. But so I'm very backwards. But like the book that I'm currently writing is coming out strong for hormones, man. I'm sick of these
Good.
books that are like, well, we need more research. We don't really know. Like, I'm sick of the soft midlife hormone books. Like,
Yeah.
I'm basically like, as much shit as they give the book Feminine Forever, which had its issues, but was very pro estrogen and women taking medications, of like, I will give you the information. You make the decision. I'm not here to
Hmm.
say everybody needs to be on hormones, but women need a freaking book that is going to have their back when they're like, we have never lived this long on a global scale ever before. We're newbies. We're literally bloodletting with leeches on figuring out longevity at this point. And I truly believe hormones are part of that.
Oh, absolutely. If you've ever seen someone on hormones versus someone not on hormones, like you can see,
I tell
yeah,
people this. I'm like, you see enough 80-year-olds in clinic, you get pretty damn good at who's coming in on hormones and who's
yep,
not.
yep. I'm like,
I'm
not a
glad that
wrinkle
I'm
in
not the
sight.
only one. I'm like, I
No,
don't
no.
I'm like enough, you get the 80-year-old coming in sneakers and a hoodie, finishing pickleball, gonna go pick up her grandson and take him out to dinner. You're not curious that she's on testosterone, estrogen, and progesterone.
Yeah, there's a it's a secret to vitality. And in a way that men have been very privy to, and we are urologists, we prescribe them to them, right? And we've never once been questioned. Like we have very strict guidelines, we have all the things. It's never once been, do men even deserve this? It's, well, as soon as they start having symptoms and they're bothered by it, here's an option for them, and they can choose or pick and choose if they want. And then I feel like all the urologists in the space, all the sex ed people, all we're asking for is equality, right? In the clinical experience, because the current thing that we experience way too much is, I went to my doctor, they told me, and I wanted to figure out what I could do about menopause, and they said nothing. Here's an antidepressant, when there's all these options for them that are safe when done safely and effective, and like not only improve your quality of life, but improve your overall health. And yet your doctor that is uneducated in menopause and has their own biases and is truly going off of feelings over facts is gatekeeping this information and even this ability for you to even have access to it. Fuck that. Like that just got so annoying.
This is why we're
Like,
friends, because I feel
yeah,
normal around you.
it's just
It's
wild.
very
It's like,
normalizing for me. I mean, I agree. This is an equality issue, 10 times out of 10 for me. And women have the very unfortunate problem of having to prove that their suffering is enough in the eyes of
yes,
their doctor. Men do not have that bar to cross.
yes, we are just straight up like, no, is your number low? Perfect. Here you go. Like, is your
Yep.
number low? And are you bothered? Great.
Yep.
Like,
If men had a drug that decreased their chance of dying by 30% between the ages of 50 and 60, in addition to decreasing the risk of heart disease and cardiovascular events by up to 50% between the ages of 50 and 60, they would all be on this drug. It's
it's
called
so,
estrogen.
yeah, it's so fascinating, the mentality, right? Like, even when you talk to the naysayers about this, they're like, it's just, there's just not enough information, and blah, blah, blah. And I'm like, step back. You have to understand that because of the poor funding in research, and there's just no one, like, there has not been the ability to even garner information. It's not like the people that say there's not enough, there's like the research is dangerous. It's like, well, there's not enough research. And also, you don't have the adequate funding in women's health to then do the research. So, what is the research that is already available? And it's actually overwhelmingly positive pro hormones. But then let's take a step back and think about things. And I think the testosterone, like the way that I think about it, or the way that why things are so different is when I still remember I was like suggesting that we do intrarosa, like as part of my, like I had a clinical algorithm, intrarosa, very important for vulvar health, estrogen and testosterone, very important for your vulvar health. And I had this clinical pathway and I wanted the whole clinic to adopt it because I became the UTI and chronic pelvic pain person. I was like, fine, I'm happy to do that because it's actually pretty straightforward for me. And also, then we have to do a clinical protocol all across the board, right? Like that's just what I need for these. If I'm going to take on these patients, like please do my clinical protocol. I had a gynecologist be like, "Oh, testosterone, that's too dangerous." Like literally started honing in on me, and I was like, "Ma'am, there's a lot of studies that actually show how safe intrarosa is and how it's effective against UTIs, recurrent UTIs, and like vaginal pain." But it was again this feelings over facts, like that. She felt that women shouldn't get testosterone, but the facts actually demonstrated that it's super important, right?
Yep.
And that kind of like one, we're going for feelings over facts, one, and then two, there's this kind of also this accepted mentality outside of urology when it comes to women of, well, did you die though? There's not really like this like, or was your quality of life good? Because it speaks to that argument of, well, estrogen's just dangerous. It's dangerous, it's dangerous. We shouldn't give it to anyone. It's like, okay, well, that's way too far over there. And they're like, well, back in the day, we used to give it to everyone, and then there was complications and the WHI and blah blah blah. And I was like, well, why isn't there a happy medium? Why isn't like we have with testosterone? We have a range of testosterone that we know is safe. And so why don't you all start figuring out what the safe ranges of estrogen could potentially be, right? Like, but instead, it's an all or nothing type of thing. They give all the hormones and we don't check or see how safe it is, or we give them nothing. Because if you're giving people hormones without doing it safely, which I think you should be checking hormones for safety,
Mhm.
and then they have a bad outcome, it's then confirming your bias that hormones are dangerous. And then you say no hormones. I can't imagine a land where we give testosterone without checking labs. Like
Right.
that's just wild to me.
Yeah.
And yet that's what our current guidelines are. So even if
Yeah.
you can finally get to hormones, the guidelines aren't even protecting you in a way that makes sense to me.
Yeah. I don't know if you saw the Atlantic article that Rachel Gross just did this
Yes,
week.
yes, yes,
Yeah, it
yes.
was awesome. I was quoted in it basically saying, like, listen, trans care has it figured out. They care about quality of life and your sexual health. They're comfortable with it. It's part of the conversation. The amount of women who responded on my Instagram saying they get their menopause hormones from trans clinics because they feel safer, they feel the care's better, they feel they don't have to explain themselves.
Yes.
And I was like, wow, that was super fascinating. And my
Yes.
second point is people are like, how do we know that testosterone is safe in women? And I'm like, because we've been giving 10 times the dose to the women who want to live as men for trans care. And they're not dying.
Yeah.
So
Yes.
I'm like, you guys, we've got like high dose studies on
Yeah.
women. They're thriving. They're happy for it. They're doing great. So physiologic dosing at 1/10 that dose is very safe. But it's like logic goes out the freaking window.
It absolutely does. And that is the most frustrating thing when it comes to this work is that you're constant because it it just goes to show that there's a cultural phenomenon that when you choose to decide to take care of women, you're going to also have to combat the the dogma. You're going to have to combat a lot of a lot of internalized sexism that is ingrained in
Yeah.
medicine, right? I mean,
Yeah,
the fact
I see this in
that,
surgery too. And this is when I started realizing our safety bar for women under the veil of protection is very different than the safety bar for men. Example, women got some mesh for the pelvis, for the prolapse, and for stress incontinence. They pulled slings in addition to prolapse mesh off the market in multiple countries, therefore leaving many leaky ladies with absolutely nothing to help them.
yep.
We put penile implants in men who want to have erections. Horrific side effects from this when it goes bad. They erode through the tip of their penis. They've got horrible skin infections. We haven't pulled that from any country.
Not a single one. Not one.
Not
Can't
a
even
single
think.
one.
Not a single one.
Because we want to protect, air quotes, protect the women, we end up causing more women more harm.
Which is so funny because, you know, it's again speaks to that paternalism, but a lot of I'm a strong believer that if they were to actually do trials where they actually first gave vaginal estrogen or vaginal DHEA and then implanted mesh, we would not have seen that high erosion level.
100%.
If
The
you are,
amount of mesh erosion that I see in women who aren't on vaginal estrogen.
it's like without
You've
a horse,
got to
without,
take care of the mesh afterwards.
yes, you have to first make sure that it's like surgical principles, right? It's so interesting how surgical principles kind of go out the window when it comes to when we start talking about sexual health and women's sexual health. If I am a surgeon implanting a foreign device, we know that we want to have healthy tissues to before you're inputting any sort of foreign device in. Like that is in a perfect world, if you could have perfect tissues, you're going to have a higher rate of like mesh device take, right? No extrusion, no erosion, none of the thing. The beauty of the vulva is that you can have perfect, healthy tissues, but so many, because of our poor, overwhelming understanding of and training in female sexual health and understanding how important vulvar health is and how to maintain the vulva. Like, team, you can have the same vulva at 20 at 100. There's no reason other than medical neglect. Like, and so if they had been doing good science and doing good surgical practices by optimizing the surgical tissue before then implanting a foreign object, you would have had like this conversation would have never happened. And this is what happens in women's health time and time again. They are doing practices that doesn't actually take into consideration their physiology. And then when they have poor outcomes, they're like, it just feeds their confirmation bias that like this is what happens when you decide to care about women's health. That's why we shouldn't do it. They should just suffer, but they're alive. So
Right. No, exactly. Yeah, I actually just heard this story. A patient just told me this. So a couple of years ago, I did a gynecologist did a hysterectomy. I came in to do the sling.
Mhm.
And the patient was told by another gynecologist that I'm the one who should do the sling, right? So she had to tell her gynecologist, I don't want you to do the sling. I want Casperson to come in and do the sling. And the gynecologist said, well, you know, she's going to make you go on vaginal estrogen then. And I'm like, and what did I do? And the patient's like, you made me go on vaginal estrogen after my
Yes,
sling. And I'm
yes,
like, yeah,
as
because I'm in the right on that one.
yes.
100%.
As a scientist, as a surgeon, you want healthy tissues to help optimize healing, period. I don't want to hear any conversations otherwise. Like I was in the OGS, it was a professional society, and they were creating a task force for sexual health. And they, you know, the group of gynecologists said, "Oh, we are not doing a great job. Let's bring in our colleagues that are in sexual health to help us create a research task force." And one of the things I talked about was the importance of vaginal hormones in vulvar health and surgical outcomes. And one of the surgeons was literally like, why do we need healthy tissues? And I was like, why are you a surgeon? Like what are we talking about? What, this is wild to me that we as surgeons are being like, if there was a way that we could optimize the tissue before doing surgery and ensure the best patient outcomes possible, that's easy, safe, effective, why would you not take that? Why would you not do that for the patient? There is a cognitive dissonance when it comes to taking care of women that I truly do not understand. And I'm so glad that I have my urology colleagues, and there's amazing gynecologists that also get this and see this and are speaking up about this.
Mhm.
But we need so many more people. And so I just,
Oh, yeah, the despair. I mean, the stories go on and on. I had this woman who was seeing a primary care physician in town for her menopausal hormones.
mhm.
Every time she wanted to change a dose, the physician made her stop her hormones for 3 months, recheck her hormones, and then start her on a new dose. This is a postmenopausal person who doesn't make any hormones. And so I'm like, so every 3 months when you haven't been on hormones, what are your labs? And she's like, yeah, I have low hormones. And I'm like, yeah, because you're postmenopausal and you don't. And she's like, I'm miserable because she makes me stop the hormones for 3 months before I can start my new doses. And I'm like, if a man was on testosterone and we wanted to change the dose, do we make him stop the dose for 3 months before we give him a different dose? No. Like,
No.
it is one step underneath the covers to hold up what we do to women to men and to say, does it make sense?
Yes, that is it. Like, and I think this is our superpower, is
It's our
to be able to say, like, because if you're trained and that's all you know, that's all you know, versus if someone comes in and says, hey, this actually could be better. And this is how. I think this is why we are so vocal. This is why we say so much. You can't like turn on anything without hearing one of us saying something. But there's a reason, we once you know better, you have to do better. It's very much see something, say something. And we are seeing these experiences in our clinic and speaking up and speaking out and trying to change a system and get everyone riled up like they should be, right? Like every single human being with a vulva, and anyone that loves or knows anyone or is important that has a vulva, should also be advocating for these things. All doctors should be advocating for these things. Like if I were a neurologist and actually truly knew how much better my life would be if my patient was taking estrogen and I could prevent things like Alzheimer's, I would also be advocating heavily. But because, and a cardiologist, I could actually be saving myself, an emergent cath because my patient was actually taking estrogen and was protecting their heart. Amazing, right? Like, but these doctors, they're just like, oh, it's women's health, so it's not important to us. We don't need to know. And it's like, no, we all need to know. And I just am so thankful that I get to share a space with you of people that are speaking up and speaking out and actually bringing the evidence to people directly in an easy way that is helping them advocate for themselves. So, ooh,
Thank you. Yeah,
I love
I got a lot of inspiration because people ask me, like, how do we change? How do we educate all the doctors? How do we blah blah blah? And I'm like, we try, but that's not how we change the world. We are not going to change the world. Doctors are busy. They can't go learn all this all the time, right? They're not going to do it on their own. They're not going to have the lightning strike their brain like I got the lightning to strike my brain. I get a lot of inspiration from the AIDS epidemic and
Yes.
the stand-up community
Yes.
because people were suffering, people were dying. They didn't see the medical community moving fast enough. They didn't see access to this medication coming from top down. And so they started to speak up.
Yeah.
And that's how the HIV epidemic changed.
Yes.
It'd be
It was.
like they demanded it. And I get a lot of inspiration from that, specifically with the menopause movement and the hormone movement, to be like, listen, you know what changes a doctor? 200 women showing up to that office one at a time saying, I want vaginal estrogen. It's time for me to go on
Exactly.
estrogen. I've read that the studies are safe. This is a paper for how I think we should start testosterone. Can we just try it? And I'll come back in 3 months and let you know how I'm doing.
Yeah.
That's how this is changed. We cannot wait for the top to change it for the people. The people are going to come in. And that's my advocacy of why I will keep podcasting, why I will keep writing the books. Because at the end of the day, nobody cares more about your health than you. You've got to go advocate for it.
Yes. I love it. I absolutely love it. I co-sign it. It's something I deeply, deeply agree with. This is going to that movement of the ACT UP movement was
Act up. I said
truly
stand up. Yep, act up.
truly inspirational, right? Like it was a time you got to see the power of patient advocacy. It was so much coordination, so much work, so much death, dying, and suffering had to happen before that. And I get chills when I think about that grassroots movement creating so much down the line change. And I want that for women. I want 50% of the population to also kind of stand up and understand that they're not getting remotely the right standard of care in a lot of them. And we can reimagine a world where their healthcare actually takes into consideration how their body works and also takes into consideration their quality of life. Like, why aren't we advocating for these things? And I'm so, 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 so glad that you were here today to talk about this. And it's just so nice to know that, you know, we're not in this fight alone. And also I hope patients and not patients, but users, customers, patients, all the things, people, as they're interacting with the healthcare system, understand that it is deeply flawed and understand that they are powerful beyond belief. And yeah, and in a perfect, like, yes, in a perfect world, we snap our fingers and it'd be better, but that's just not how the system works. Um, so yeah, so thank you so much for being here. Where can people follow you, support, subscribe, do all the things, all the stuff?
All the stuff. Podcast is called You Are Not Broken. Website is kellykaspersonmd.com. Book is called You Are Not Broken, Stop Shoulding All Over Your Sex Life. Currently not available, but pre-order coming back out, re-released September 2024. And I hang out on Instagram. It's my fave. So Instagram is Kelly Casperson MD.
Excellent. And then if there was one thing that you could tell the listeners that you wish that they knew about their health or going through the healthcare system, what would that be?
That doctors are people too, but they're stressed, they're strained. They really do want to care for people, learning how to communicate well. And I always apologize. Like, I'm sorry that the burden's on the woman to go get educated. Like, but the world isn't perfect, and it's what you can do. And although menopause is not a disease, things happen when your hormones change, and diseases happen more commonly because of it.
Yes.
And
Yes.
I think the lack of education of like that the world just thinks menopause is a hot flash completely blows over what the profound change is actually happening in your body.
Yeah.
So just to really educate women of like, listen, it's on us to change this and to realize we are brand new at learning how to live 30 years post menopause. We are brand new at it. So why not try to figure it out? Like, be profoundly curious. The lack of curiosity is astounding to me of like, well, we figure it out. You don't realize what feeling good feels like until you feel good. And then you're like, oh,
Yeah.
it's real good.
Yeah.
So it's as much as you can to say, you know, you're in charge of this amazing spaceship that you have to be on this earth with. Try to take care of it.
Yeah, I love it. That's fantastic advice. And Kelly, thank you again for being here and sharing such nuggets of wisdom. Loved having you.
Thank
And
you.
yeah,
Till next time.
yes.